This is the first lecture of neonatal jaundice. And the objective of this lecture was to review bilirubin pathway or metabolism, explore risk factor, causes of indirect hyperbilirubinemia, causes of jaundice in the first 24 hours of life, and jaundice that may persist more than 2 to 3 weeks, which is called prolonged jaundice. Also to distinguish between physiological and pathological, and distinguish between breast milk jaundice and breastfeeding jaundice, and be able to diagnose Caernoctorus and discover the risk factor and the prevention. It is either indirect or direct, occur in 60% of term infants and 80% of preterm infants. Bilirubin metabolism. Bilirubin was derived from heme and 75% of heme from senescent RBC in the reticuloendothelial system, and 25% of heme from hemoglobin of ineffective erythropoiesis in the bone marrow, and from myoglobulin, cytochrome, and so on. Here we can see heme by the effect of heme oxygenase, it will be converted to biliverdin, and this by the effect of biliverdin reductase, it will be converted to bilirubin. This bilirubin, when elaborated in the bloodstream, it will be water insoluble, so it cannot be excreted in the urine. This indirect unconjugated bilirubin will bind to albumin. This albumin bind bilirubin is not toxic to CNS. When the binding site of albumin becomes saturated with bilirubin, if a free unconjugated bilirubin is high or competitive compound as sulfonamide, free fatty acid, this will lead to increased free bilirubin, which may enter CNS and causing toxicity and Caernoctorus. This binding bilirubin, which is indirect bilirubin dissociated from albumin at hepatocyte here, were bound to cytoplasmic ligandin or Y protein for transport to smooth endoplasmic reticulum. Inside hepatocyte in the liver, conjugation will occur when indirect bilirubin converted by uridine diphosphate glucuronyl transferase. This is the enzyme. It will be converted to monoglucuronide and diglucuronide, which is water soluble, have the ability of the biliary and renal excretion. Now, the conjugated bilirubin is excreted by the biliary system to enter the GIT, where some of it metabolized by colonic bacteria, which is bacterial flora of the colon, to form urobilinogen and then stercobilinogen, which may be further oxidized to stercobilin that give the stool color. That's why in obstructive jaundice or cholestatic jaundice, it may be appear a colic stool because there is no stercobilinogen or stercobilin. Some of the urobilinogen here, it will be reabsorbed and excreted in the urine, reaching the kidney and excreted in the urine, where some of it further oxidized to urobilin, which gives its characteristic urine color. Now, some of the conjugated bilirubin here in the GIT, it may be reconverted to unconjugated bilirubin by intestinal bilirubin glucuronidase, then again reabsorbed, go back to the circulation, reaching the liver. This is called enterohepatic circulation. This may cause increase in indirect bilirubin. Enterohepatic circulation may be increased in some newborn and patients with pyloric stenosis, intestinal atresia, meconium, ileus, and so on. but it decreased by intestinal bacteria. The risk factor for the development of severe hyperbilirubinemia in an infant of 35 or more weeks of gestation may be major risk factor, minor, and decreased risk factor. Now, what is the major risk factor? It includes jaundice observed in the first 24 hours, blood group incompatibility, other hemolytic disease, gestational age between 35 and 36 weeks of gestation, previous siblings receiving phototherapy, cephal hematoma or significant bruising, exclusive breastfeeding if nursing is not doing well and weight loss is excessive. And I mean by nursing is not doing well by infrequent feeding of the baby. East Asian race. Now, what is the minor risk factor? It includes gestational age 37 to 38 weeks of gestation, jaundice observed before discharge, previous siblings with jaundice, infant of diabetic mother, maternal age more than 25 years of age, and male sex. Now, what is the decreased risk factor? Gestational age more than 41 weeks of gestation, exclusive bottle feeding, and the black race. What is the causes of indirect hyperbilirubinemia in neonates? First of all, we have physiological jaundice, which is the most common cause, breast milk jaundice, overproduction, or hemolysis, which include many causes. The most important and most risky cause is blood group incompatibility, like Rh, ABO, and subgroup incompatibility. RBC enzyme defect as G6PD deficiency, pyruvate kinase, spherocytosis, alpha thalassemia, acquired hemolysis by infection, the drug as vitamin K and sulfonamide, extravascular bleeding as petechiae, hematoma, pulmonary hemorrhage, or any occult hemorrhage. Polycythemia as in maternal-fetal or fetal-fetal transfusion, and so on. Increase in enterohepatic circulation as in cases of meconium, plaque syndrome, Hirschsprung, pyloric stenosis, and so on. Damage or reduce the activity of transferase, uridine diphosphate glucuronidase transferase, as in hypoxia, infection, thyroid deficiency, or genetic deficiency of this enzyme, as in regular nature. Decrease bilirubin uptake across the hepatocyte, as in cases of drug or breast milk jaundice, or as hypothyroidism. Miscellaneous as sepsis, UTI, hypoglycemia, infant of diabetic mother, and the drug such as oxytocin. Now we talk about physiological jaundice, which is the most common cause of neonatal jaundice. It is usually appear second or third day of life in full-term infant, third or fourth day in preterm infant. Level reach peak usually 6 to 8 milligram and not more than 12 milligram per deciliter in the third day in full term, and usually 10 to 12 milligram and not more than 15 milligram in the fifth day in preterm infants. Usually disappear by 4 to 5 days, rarely by 7 to 10 days in full-term infant, and usually disappear 7 to 9 days in a preterm infant, and rarely by 2 weeks in a preterm. Increase of bilirubin should be not more than 5 milligram per deciliter per 24 hours, or not more than 0.5 milligram per deciliter per hour. Causes: increase production of bilirubin due to increased RBC volume per kilogram body weight, and decrease RBC survival. that will increase load of heme in the blood. Increase enterohepatic circulation by high level of intestinal glucuronidase and decrease intestinal bacteria. Effective uptake of bilirubin from plasma by decreased ligandine. Effective conjugation due to physiological decrease in enzyme uridine diphosphate glucuronidase transferase. Also physiological decrease hepatic excretion of bilirubin. Now, physiological jaundice may be exaggerated. I mean increased peak and duration, where there is a multiple risk factor that mentioned previously, as breastfeeding, infrequent breastfeeding, male sex, cerebral hematoma, cutaneous bruising, polycythemia, weight loss, dehydration, and so on. And so the peak and duration may be more when there is a multiple risk factor. Diagnosis of physiological jaundice by exclusion of known cause of jaundice on the basis of the history, clinical finding, and lab data. Treatment self-limiting, ensure feeding, and good follow-up for TSV and PCV or any abnormal clinical finding that may indicate pathological jaundice. Here I mention PCV because it is very important to follow up the PCV. When there is severe decrease in the PCV, it may indicate hemolysis that may indicate blood group incompatibility or hemolytic disease. Now, the jaundice should not be regarded as physiological, should not be regarded as physiological, and should be regarded as pathological, and should be investigated when we should think that this jaundice may be pathological. It appears in the first 24 hours when TSV increasing more than 5 mg per deciliter per 24 hours or more than 0.5 mg per deciliter per hour. TSV more than 12 mg in full term or more than 14 mg or 15 in preterm infant. Duration of jaundice more than 10 to 14 days. Jaundice present at or beyond the age of 2 weeks. Also, when jaundice associated with sick infant, poor feeding, lethargy, this may indicate pathological. Also, when associated with pallor, hepatosplenomegaly, all this may indicate pathological jaundice. Sign of Kernicterus indicate pathological jaundice. Family history of hemolytic disease should be investigated for pathological jaundice. TSV concentration approaching exchange level or not responding to phototherapy. Instead of phototherapy, jaundice increasing. Direct hyperbilirubin, when the direct bilirubin more than 20% of total or associated with pale stool, dark urine, and positive for bilirubin. All these points may indicate pathological jaundice. Now, what is the causes of jaundice in the first 24 hours? First of all, we have hemolysis or erythroblastosis fetalis, and the most common was ABO incompatibility. Then we have RH incompatibility, other cause of the hemolysis, G6PD, spherocytosis, and so on. Then we have concealed hemorrhage like cephal hematoma, hepatic, splenic hemorrhage, or any hemorrhage. Sepsis, congenital infection like CMV, orbital toxoplasmosis, and so on. What is the causes of prolonged jaundice? Duration more than 2 weeks and may persist in and beyond the first month. Causes include hemolysis, hypothyroidism, follicular nut jar, breast milk jaundice, intestinal obstruction and pyloric stenosis, idiopathic neonatal hepatitis, hyperelimination or total parenteral nutrition, hepatitis, cytomegalovirus infection, syphilis, toxoplasmosis, and torch infection. Galactosemia, biliary atresia, insufficiency bile syndrome, which is called severe hemolytic anemia. The first 5 causes, as you see, all of it is indirect hyperbilirubin. while from the 6th till 11, most of it was direct hyperbilirubinemia. Now we talk about breast milk jaundice. One of the causes of prolonged neonatal unconjugated hyperbilirubinemia, when patient may or may not have physiological jaundice at the beginning, develop significant elevation of bilirubin between first and second week, usually after the 7th day of life, reaching maximum between 10 to 30 milligrams, rarely more than 20 milligrams, during the 2nd and 3rd week. The cause is unclear, but in some the milk contains glucuronidase that increase enterohepatic circulation. If breastfeeding continues, the jaundice persists for 3 to 10 weeks at lower level. If we stop breastfeeding, there is rapid decrease, reach normal within few days without return when restart breastfeeding. Before diagnosis of breast milk jaundice, we have to exclude other causes of unconjugated indirect hyperbilirubinemia, as hemolysis, hypothyroidism, sepsis, by lab and physical examination. Treatment stop breastfeeding for 1 to 2 days. Sometimes phototherapy may need. Rarely kernicterus has been reported. This breast milk jaundice should be distinguished from a breastfeeding jaundice. Now, in breastfeeding jaundice, you have to remember risk factor. I mentioned it previously. Early onset exaggerated physiological unconjugated hyperbilirubinemia in the first week of life. In a breastfed infant, which may be due to decreased milk intake with dehydration and or reduced caloric intake. There is a frequent sleeping of the baby during early days of life, so infrequent feeding. This can be prevented and reduced by frequent breastfeeding and night feeding. Discourage giving 5% dextrose or water supplementation. So it is one of the risk factors of jaundice due to decreased frequency of feeding. Now, familial non-hemolytic unconjugated hyperbilirubinemia or inherited deficient conjugation of bilirubin. Inherited disease associated with different degree of decrease in the hepatic uridine diphosphate glucuronine transferase. It is a regular Najjar type 1 syndrome, complete absence of the enzyme, and type 2 partial defect in this enzyme. Type 1 regular Najjar, absence of uridine diphosphate glucuronine transferase. It is rare, transmitted as autosomal recessive. Clinically, it was severe indirect hyperbilirubinemia with no hemolysis. So, when we see a severe hyperbilirubinemia with no hemolysis, we should think of a regular Najjar type 1. Develop in the first 3 days of life, which may reach 25 to 35 milligrams per deciliter, and during the first month may continue after that. Kernicterus is a common complication. Diagnosed based on high level of unconjugated bilirubin with no hemolysis, no response to phenobarbital. This is just to be differentiated from type 2, which respond to phenobarbital. Definitive diagnosis by measuring hepatic enzyme glucuronide transferase activity in the liver specimen. Also, DNA diagnosis by genetic testing. Treatment, neonatal period may need continuous phototherapy and repeated exchange transfusion may be needed to prevent kernicterus. even after neonatal period. Cholestyramine or agar used to bind photobilirubin product and thus interfere with enterohepatic circulation. Treatment of infection or any illness to prevent development of kernicterus. Plasmapheresis may be of benefit. Metacloporphyrin can be used to prevent heme oxygenase. I talk about it in the next lecture. Genetic engineering, enzyme replacement, hepatic transplant may cure the disease. The newest treatment was liver direct gene therapy. Type 2, which is usually milder, also autosomal recessive due to partial defect in hepatic uridine diphosphate glucuronidase enzyme, may be presented similar to type 1 or may be less severe even occasionally without neonatal manifestation. TSP range at the beginning may be compatible with physiological or pathological. Kernicterus is unusual. Jaundice respond dramatically to treatment with phenobarbital. Now we talk about kernicterus. Kernicterus is a neurological syndrome resulting from deposition of indirect bilirubin in the brain cells, especially basal ganglia. When the bilirubin exceeding bilirubin binding capacity of the albumin, free bilirubin will cross blood-brain barrier and diffuse to brain cell and causing cell damage and kernicterus, or what is called bilirubin encephalopathy. The precise level of indirect bilirubin is toxic to the brain and duration of exposure was unknown. Kernicterus occur in infants with bilirubin more than 25 mg per deciliter, and 90% of whom were previously healthy, predominantly breastfed, term and near-term infant. A healthy full-term infant with physiological jaundice or breast milk jaundice with no hemolysis may tolerate a concentration slightly higher than 25 mg per deciliter with no apparent health effect. There is some risk factor that increase possibility of kernicterus at lower level of bilirubin, which may damage blood-brain barrier or decrease bilirubin binding capacity of albumin, as hemolysis, hyperosmolality, intraventricular hemorrhage, acidosis, hypoalbuminemia, increased free fatty acid, hypothermia, drug, hypoglycemia, hypoxia, sepsis, asphyxia, meningitis, and premature. So, for example, premature low birth weight infant develop kernicterus at lower bilirubin level than 20 to 25 milligrams. It may be need and may develop kernicterus even at 10 milligrams per deciliter in very low birth weight infant. Also, patients with septicemia, if he is without septicemia, may develop kernicterus at 20 or 25 milligrams, but with septicemia may develop at lower level. It may develop below 20, especially if there is other factor that may decrease the level of developing kernicterus. Now, what is the clinical manifestation of kernicterus? Usually, the onset in the first week of life. Signs and symptoms usually appear at 2 to 5 days in full-term infant and 7 days in preterm infant, but it can occur at any time in neonatal period. It is presented with acute form and then develop the chronic form. In acute form, the early signs and symptoms include poor feeding, lethargy, loss of motor flex, hypotonia, high-pitched cry, and irritability. These signs are usually indistinguishable from signs of sepsis, asphyxia, hypoglycemia, or intracranial hemorrhage, because all these may develop also poor feeding, lethargy, and loss of moral reflex. So the early signs include poor feeding, lethargy, loss of moral reflex, hypotonia, irritability, and so on. Then, 2 to 3 days after the initial phase, at the end of the first week and in the second week, the patient becomes severely ill with severe respiratory distress, bulging fontanelle, fever, hypertonia, apostotonus, and retrocols, shrill high-pitched cry, convulsion, stiffly extending their arm with inward rotation with fisting clinch. Here you can see the fist clinch in the hand. You can see the arching of the neck and arching of the back. Here it's called apostotonus and retrocolis. Many infants who reach this stage are dying, and most of the survivors usually develop later the chronic form, in which complete neurological syndrome, but may appear to recover for 2 to 3 months, appear with little abnormality, and during the first year hypotonia, active deep tender reflexes, obligatory tonic neck reflexes, and delayed motor skill. So it may after the severe form, he will develop neurological syndrome, but appear to be at the 2 to 3 months with little abnormality, then develop in the first year, apostotonus, muscle rigidity, irregular movement, hypertonia, and convulsion. Then gradual development of complete neurological syndrome, which include choreoathetosis, involuntary muscle spasm, extrapyramidal sign, fit, mental retardation, dysarthritic speech, deafness, spastic quadriplegia, teeth discoloration, and animal dysplasia. Now we talk about the prevention of kernicterus. Now, some potentially preventable cause of kernicterus should be prevented. These include the preventable causes: early discharge, less than 48 hours, with no early follow-up within 48 hours of discharge. No check-up of bilirubin in infant jaundice in the first 24 hours. Failure to recognize the presence of risk factor for hyperbilirubinemia. Underestimation of the severity of jaundice by clinical visual assessment. You should always depend on lab assessment. Lack of concern regarding the presence of jaundice. Delay in measuring serum bilirubin level despite marked jaundice, or delay initiation phototherapy in the presence of elevated bilirubin. Failure to respond to parental concern regarding jaundice, poor feeding, or lethargy. No parental screen for blood group incompatible. All these preventable cause of kernicterus. So, in prevention, we should do early screening and follow up any newborn after delivery and after discharge for hyperbilirubinemia and for the presence of risk factor by history examination and lab on need. Early measurement and follow-up of serum bilirubin level in the any jaundice unit and the treatment accordingly. Avoid visual assessment, but by lab assessment. First, 24-hour jaundice must be evaluated for possible hemolytic disease, which is a risky and dangerous problem. Parental communication about the infant skin color and education about potential risk and the neurotoxicity that include kernicterus and brain damage. Mother should be advised to nurse infant every 2 to 3 hours in order to ensure adequate hydration and caloric intake. Avoid supplementation of the glucose and water. The treatment of the condition that increase risk of kernicterus at bilirubin level, lower bilirubin level like sepsis, acidosis, asphyxia, these increase the risk of kernicterus at lower bilirubin level. So all these conditions should be treated. The prevention of Rh isoimmunization, where any pregnant Rh negative woman giving her human anti-D globulin when she delivered Rh positive baby or developed